Thank you for having me speak today. I'm going to share my team's findings on the global burden of mortality due to hepatitis B and hepatitis C from the 2019 iteration of the Global Burden of Disease Study. Some of you may be familiar already, but in brief, the GBD is a systematic scientific effort to quantify the comparative magnitude of health loss for an ever-lengthening list of now 369 diseases and injuries by comprehensively identifying all relevant data from multiple measures, adjusting them to a reference standard, and integrating them in predictive models that leave no blanks, using temporal and geographic patterns and covariates to make the best estimate possible for both sexes for all 204 locations and 23 age groups in our framework for every year from 1990 to the present. We strive for internally consistent estimates and standardized approaches across the diseases. In the case of viral hepatitis, this approach is particularly well suited to answering questions such as, how does viral hepatitis burden compare to other infectious global diseases such as HIV or TB? Or what if there's no surveillance or epidemiologic research on HBV-related mortality in a country? Does that mean that we don't know anything? Or what if one country conducts verbal autopsy studies, but its neighbor has a strong vital registration system? How do we make valid comparisons between those two places? Or what if our detection methods improve over time? How does that affect comparisons to a baseline? In GBD, for viral hepatitis-related mortality specifically, we work in a somewhat backwards fashion, starting from broad mortality envelopes that we can estimate more confidently, and then assigning portions of those estimates to specific infections in a later step. Specifically, we estimate mortality due to cirrhosis, liver cancer, and acute hepatitis without regard to etiology. We then separately model the proportions of cirrhosis that are due to hepatitis B, hepatitis C, alcohol, NAFLD, and other etiologies, and multiply each by the total mortality due to cirrhosis to estimate mortality due to cirrhosis due to that etiology. Our approach is similar for liver cancer, and we also run separate models of mortality due to hepatitis A, B, C, and E, and rescale those results to sum to the estimates of total acute viral hepatitis mortality. Looking specifically at cirrhosis, you can see here on the left that we have vital registration and verbal autopsy data reporting on cirrhosis deaths in all the countries on the left-hand map shown in blue, with more data in countries of more intense blue. We use these data in an algorithmic modeling tool that tests many combinations of covariates and model form to find an ensemble model with high predictive validity for 20% data holdouts. Covariates in this model relate to all etiologies of cirrhosis and include hepatitis B surface antigen seroprevalence, anti-HCV antibody seroprevalence, per capita alcohol consumption, diabetes prevalence, hepatitis B 3-dose vaccine coverage lagged by 10 years, and injection drug use. There are also covariates for general parameters such as sociodemographic index and healthcare access and quality index. Predictions from this model are made for every year, age, sex, and location in our framework. Thus, estimates in years and countries without data are based on spatial and temporal patterns and relationships between covariates and the data that we do have. Separately, we run cirrhosis proportion models, that is, models of the proportion of cirrhosis due to hepatitis B, due to hepatitis C, due to NAFLD, etc. These data for these models come from cirrhosis case series extracted from published peer-reviewed public studies. And the global distribution of these data are shown for HBV in the top right and HCV in the bottom right. The data for the other three proportion models are not shown. All of these models are run using the disease modeling meta-regression tool and also use geographic patterns and covariates to help predict the proportions for years and locations without data. You'll notice, however, that data are much more scarce for these proportion models, and they rely much more heavily on predictive covariates for locations without data. A similar process is carried out for liver cancer. Again, the left-hand side shows primary mortality data for liver cancer due to any etiology. Here we also have, in addition to vital registration and verbal autopsy, data from cancer registries. And the right-hand side shows data distribution for proportion models, which come from published case series. In the case of acute viral hepatitis, We model mortality due to acute viral hepatitis of any type using data with the coverage in our map shown on the left-hand side here. And then we use only the highest quality vital registration data to model mortality due to acute hepatitis B, acute hepatitis C, acute hepatitis A, etc. separately. And then we rescale those specific models to fit the parent. I think you can appreciate from the previous slides that the mortality models, both the all etiology parent mortality models and the etiology specific proportion models, rely on predictive covariates where data are sparse. So inputs for these covariates matter nearly as much as the primary mortality data. The geographic distribution of the data used to estimate hepatitis B surface antigen seroprevalence and anti-HCV antibody seroprevalence in GBD 2019 are shown here. And you can see that they are strong in some locations where the primary mortality data are absent or scarce. Taking all those inputs and steps through to the final output, here's a map of our estimates of the mortality due to HBV, including acute hepatitis, cirrhosis, and liver cancer combined, for all ages in each location for the year 2019. Rates range from less than 1.4 per 100,000 in purple to a range of 11 to 29 per 100,000 in the deepest shade of red. Now here's the same type of map for all age mortality due to HCV in 2019. Here ranging from less than 3.4 in purple up to a range of 15 to 45 per 100,000 in the deepest shade of red, as in Egypt and Mongolia. Now, the colors on the map can tell you about the intensity of the burden across countries, but obscures the fact that premature mortality due to hepatitis B and hepatitis C are both highly concentrated into top burden countries. Here I'm presenting years of life lost, which is a measure of the number of deaths at a given age subtracted from the maximum observed human life expectancy, summed across all ages. So my y-axis here is the percent of global YLLs, years of life lost, that occur in a particular country. And then across the x-axis, you see a list of the top burden countries for YLLs due to this infection. The left-hand side is for HBV, and the right-hand side is for HCV. And you can see that for both of these infections, more than half of the global YLLs are in the top burden countries, implying a very concentrated burden. There has been, however, global progress in reducing HBV mortality, here viewed as a population rate. Each line represents a different WHO region with an aqua color representing the global weighted total, which is towards the middle of the graph. The y-axis is the mortality rate per 100,000. And then this shows progress between 1990 and 2019. You can see a decrease globally over time, largely driven by large changes in the Western Pacific region. Of note, most improvement occurred prior to 2015, the Sustainable Development Goal baseline year. And interestingly, much of this occurred less than or about 10 years after vaccination introduction, which is earlier than we would expect to see gains for a disease that has so much mortality decades out from initial infection. I will point out one limitation, that although these estimates go through 2019, most countries had only reported their viral registration data through 2016, 2017, or at the latest 2018. So later years rely on temporal smoothing, covariates for seroprevalence, and covariates for vaccination coverage. In GBD 2020, we are adding more vital registration and improving our approach to incorporating the effective vaccination for those predicted values. Nonetheless, I think the major takeaway of progress over the last 2 decades, particularly in the Western Pacific region and particularly prior to 2015, stands up regardless of what happens in those last 2 years. And this is a similar plot for hepatitis C, but here we see a global rise in mortality rates during that same 20-year time period, although with net improvements in the African and Western Pacific regions. Here again, we have the same caveat for the last 2 to 3 years of the time series, where vital registration largely goes through 2017 or so, and later years rely on temporal smoothing and covariates. Here, this may be a particular shortcoming for countries that have adopted mass campaigns for treating hepatitis C in the last 5 years. And in GBD 2020, we'll incorporate more vital registration data, plus explicitly incorporate hepatitis C treatment data from 2014 to 2019 for 26 countries. Nonetheless, the overall message here is that many regions saw flat or rising rates over the last 2 decades. I think we can understand this better viewed as a demographic phenomenon. So I'll walk you through this figure. There are 3 panels, all of which show the percent change in a mortality metric between 1990 and 2019. Blue shows the percent change in liver cancer due to hepatitis B, green shows the change in cirrhosis due to hepatitis B, and red shows the change in acute hepatitis B mortality. The black dot represents the aggregate of those 3 entities. The x-axis for each has a dotted line representing 0 for no change between 1990 and 2019. And then from top to bottom, we have global change and then each of the WHO regions. If we start on the right and view progress in terms of age standardized death rates, we see tremendous improvement for HBV across all regions. In the middle, however, we look at rates without age standardization and see that in Europe, the Americas, and Southeast Asia, liver cancer rates are actually going up, presumably due to aging populations. If we look at absolute death counts in the left-hand panel, mortality is rising for almost all regions, with the Western Pacific being a notable exception. So we can conclude from this that efforts are strong and successful in a sense, but not keeping up with aging and population growth in many locations. This is a similar figure for HCV mortality, although we see the gains in age standardized rates are smaller and less consistent. They're in the right-hand panel. And again, if we take the population age structure into account by looking at non-age standardized death rates in the middle panel, we see rising rates of mortality, particularly in aging populations. And then when we look in count space in the left-hand panel, we see rising numbers of liver cancer and cirrhosis deaths in all regions. Lastly, I'm going to compare the mortality due to viral hepatitis to a selection of other causes. Here in red, we see mortality information for HIV/AIDS. In pink at the bottom for tuberculosis. The tan and green represent ischemic heart disease and stroke. And the 2 shades of blue are hepatitis B and hepatitis C. On the left, we see death rates per 100,000 and how they change between 1990 and 2019. And we see relatively stable, although slightly shrinking rates for viral hepatitis and much larger improvements for HIV and TB. The right-hand figure shows years of life lost, which accounts for the fact that, yes, these viral hepatitis deaths often do occur later in life, resulting in less premature mortality as compared to, say, HIV. But even after accounting for these differences, we see that by 2019, the burden of mortality and premature mortality specifically due to viral hepatitis is starting to get into the same range as HIV and TB, not because of rising premature mortality for viral hepatitis, but because of a lack of improvement compared to these other major infectious diseases. So in conclusion, modeling chronic viral hepatitis mortality requires triangulation between multiple data sources and types. and some locations have sparse or no data for one or all types. Premature death due to HBV and HCV are concentrated in a small number of high-burden countries. Improvements in chronic viral hepatitis mortality have been made when viewed as an age-standardized rate for HBV, although some locations have an absolute improvement as well. And much of this reduction preceded this SDG baseline or the introduction of targeted interventions. For HCV, on the other hand, aging and population growth generally outpace mortality improvements. We also see that there's a relatively stable burden over time that contrasts improvements for other major infectious diseases. So proportionally, viral hepatitis is becoming a bigger contributor to premature mortality due to infectious disease. Thank you for listening, and I look forward to our interactive questions.